300, high ferritin more than 600, high D dimer, etc. The radiological finding, characteristically in case of pneumonia, they have usually patchy, rounded opacifications in the periphery, and by CT scan you can show it as grand glass opacities. The incubation period ranging between 1 to 14%, but majority of patients, around 95% and more, they manifest early, within 3 to 5 days. The extrapulmonary involvement is thought to be due to the presence of these receptors, the angiotensin converting enzymes, the receptors in different organs of the body. For example, the heart, kidneys, the brain. That's why the patient might present whether early or late with different extrapulmonary manifestations, as mentioned in the cases presented by Dr. Eid. Okay, now the stages of the disease, as we again mentioned earlier, the acute infection phase, which is due to active replication of the virus, and it's up to 2 weeks, or 10 days to 2 weeks. And here the PCR is always positive, and the antibody will start to be positive after 2 weeks. After this stage, the other stage starts, which is the hyperinflammatory syndrome, and it is due to the release of a huge influx of cytokines or dysregulated host response. And again, this continue for up to 2 weeks or more, and then after week 4 we start the late sequelae. The pathophysiology and the mechanism of it is not yet known. The common organ involved by the late sequelae is the lung, commonly causing interstitial lung disease, fibrosis. That's why the patients might require oxygen for quite long time. Other organ, neuropsychiatric manifestation that might stay for a long period of time, like agitation, depression, etc. The molecular diagnosis, or the gold standard of diagnosing SARS-CoV, is the RT-PCR. Here in this slide, to the left side, you can see in this study, which was published in March 2020, it showed us the different sensitivity of different specimens. So when we suspect COVID, we have to send nasopharyngeal swab in stable patient. In intubated patient, the bronchoalveolar lavage or endotracheal aspirate has higher sensitivity, more than 95%. However, nasopharyngeal swab still have a high sensitivity, about 90%. These are the radiological feature I told you about. The lower cut represent biopsy from the lung in patients with COVID, which showed hyaline membrane formation, alveolar damage, and exudates, fibrous exudate. All are features of ARDS. Who are at risk to get severe COVID-19 with its complications. And of course, it's important to mention that everybody is put at risk to get the infection, but who are at risk of getting severe and complicated disease? Older people. So age by itself is an independent risk factor to develop severe COVID-19 in addition to its complication. There are proportion of patients that might never develop symptoms. Usually those are young patients, especially children younger than 10 years. Majority of patients develop mild to moderate disease, around 85%, 14% or 15% they have severe disease, and those who have around 5% they develop critical or serious illness, and majority of them are more than 70 years old. The graph on the right side was from a study published in China. They correlate, as you can see, the mortality rate with the age. So those at age of 80 and more, they have mortality rate of around 15%. 70 to 79.8%. The lower or the younger the patient is, the lower mortality. As you can see, in a younger age group, below 10 year, they have zero mortality. The second graph on the left side, it represents the correlation between the severe disease complication and the comorbid illnesses. So in this study, they recruited more than 7,000 patients. The majority of them, more than 4,000, have no comorbid illness. So the green column, as you can see, 84% of those who did not have comorbid illness, they did not require hospitalization. Only 7% of them require hospital admission, not in ICU, 2% ICU admission. However, the other patients with comorbid illnesses like diabetes, chronic lung disease, cardiovascular disease, chronic kidney disease, all there are some of them, they still did not require hospitalization, and this rate differs from patient to patient. For example, in diabetic 42, they did not require admission to the hospital. 32% required admission to ward. In the hospital, 19% required ICU. And in this study, chronic renal disease, 24% they did not require hospital admission, 45 require non-ICU admission, and 26 require ICU admission. Also, morbid obesity, smokers, all these comorbid illnesses are considered a risk factor for severe COVID. I'll move now to the infection prevention and control strategies in healthcare setting. This hierarchy control, probably known to some of you, it's not applied only to infectious diseases, but also to any hazards. So usually we start by implementing the most effective measure, elimination. So in case of COVID-19, what we can do to eliminate the virus is by early detection or early diagnosis of positive cases, isolating them, whether home isolation or hospital isolation, and substitution when we, for example, instead of seeing the patient physically, we can use the telehealth or virtual visit to the clinic. Engineering control, they deal, of course, with the designing the negative pressure room, putting barriers or partitions between patients, like what we did in our hospital. Upon our request, our hospital engineer, they put partitions between patients, for example, in hemodialysis, in OPAT unit. Of course, that all these things should be under the supervision and the support from our administration. And the least effective, it's not least effective per se, but it is the adherence to it is the PPE. We all as healthcare workers have to be aware how to do a donning and doffing of the personal protective equipment properly. These are the summary of what I have mentioned. In addition to what I said, also there should be a clear policy and procedure of how to collect and handle specimen from a COVID patient to the lab, and also the clear policy and procedure of the transporting patient with suspected or confirmed COVID-19. What about the community? It's very important to avoid large gathering, crowded areas. And if you have to go up in a building, use the stairs instead of elevator, especially if there are a large number in the elevator. Universal masking should be continued until we get rid of this pandemic. Respiratory etiquette, when you sneeze or cough, always wash your hand or sterilize your hands frequently, especially if you touch a potentially contaminated area. So never touch your eyes, nose, and mouth before you wash your hands. Maintain appropriate distance between you and others, like 3 to 6 feet. Stay home when you are sick, when you have respiratory symptoms. And don't forget, we are in influenza season, so please make sure that you take your influenza vaccine. Now I will talk about the power of physical distancing. Scientists measure usually the intensity of infectious disease by something called R0, reproduction number. So in case of COVID, they found that R0 of COVID, that one person can transmit infection to 2.5% or 3%. So if we did not listen or reduce the social exposure, and we did not practice physical distancing, by doing some calculation, they found out that more than 400 people can get infected within 1 month. If 50% of people adhere to social distancing, less exposure to the public, especially crowded area, then the R0 will be reduced to half, to only 1.25%. So in 1 month, only 15 people will get infected. And if the adherence is up to 75%, so at the end of the day, only 2 people can get infected. This is very important to continue practicing during such a pandemic infection. Again, this is a graph taken during the avian influenza outbreak in 2009. Here you can see that the attack rate of if we practice, if they close school, it can be reduced to 60%. If they isolate 90% of the positive cases, the attack rate will be reduced to 50%. If they implement both, so school closure and isolating infected cases, the attack rate will be reduced further to 30%. And the first line, if you implement all and as early as possible, like in the first week, you can see the attack rate is below 10%, around 5 or 4%. With further delay, again, the attack rate unfortunately will increase. So it's not the implementation alone, it's the implementation and the early timing of practicing these kind of prevention and control strategies. So what I want you to remember, and when you are in public, is the 3 ways to stop COVID: wear mask, wash or sanitize your hands, and watch your distance between other people. Keep always 1.5 to 2 meters. I think you know the COVID case definition. I don't want to go through it. Everybody should know it by now. The general outline of COVID-19 management, of course, you need first to categorize the severity of illness, whether it's mild, moderate, does the patient need hospital admission, and in general, you need to treat the symptoms. For example, in case of fever, use paracetamol. If patients need oxygen, you have to give him oxygen supplement. For critically ill patients, of course, they need to be transferred to ICU for close monitoring. They might require mechanical ventilation, vasopressor support, etc. And don't forget, in case of especially severe to critical cases, to put the patient on DVT and PE prophylaxis. This graph just represents the phases that we talked about: the asymptomatic, mild, moderate, and severe critical cases. All of them require isolation. The isolation differs. For example, asymptomatic, mild to moderate, home isolation. Some of the moderate cases and severe critical, of course, they need hospital isolation. And the therapy or the potential therapy acts according to the stages. So, for example, during the viral replication stage, usually here is the place of antiviral therapy, which is up to 10 days, 14 days. After that, the role of antiviral therapy is almost diminished. So the role of the anti-inflammatory by the beginning of the hyperinflammatory syndrome. Here the role of anti-inflammatory agents like systemic corticosteroid, some immunomodulatory agent will work. Again, here the stages. So by now you know that we have different antiviral like remdesivir, favipiravir, different other drugs used initially like anti-malarial drugs, hydroxychloroquine, etc. And the anti-inflammatory agent is the corticosteroid and the tocilizumab that we used in our patients. The different potential agents work in different ways. Some of them, they prevent the entry or the attachment of the virus to the angiotensin converting enzyme receptor. Some drugs act by inhibiting the replication of the virus, and other work by reducing or attenuating the host immune response. Just quickly, I'll go through the latest guidelines from the living WHO guidelines. The strongest evidence now are in both the corticosteroids and the remdesivir. So in regard to corticosteroid, WHO, based on the systematic review and network meta-analysis, they strongly recommend using systemic corticosteroids in severe to critically ill patients. Why? Because it was found that it reduced mortality, it reduced also the need of mechanical ventilation, and for those who are ventilated, it reduces the duration of mechanical ventilation, and the other also important outcomes. And the second recommendation in regard to systemic steroids is the use in non-severe cases. They recommend strongly not to use systemic steroids in non-severe cases because it did not show to improve any of the important outcome in patients with COVID. Remdesivir, again, through this systematic review and network meta-analysis, they did not find any benefit so far that remdesivir might improve outcome in patients with COVID in regard of mortality, mechanical ventilation, time of clinical improvement, etc. But they said, and this is based on the current available data, but it might help in subgroup of patients or subpopulation of patients. But for now, they cannot recommend this. We should wait for further or more important evidence, more larger evidence. Okay. Now, briefly, what we did, this summarize what we did to fight COVID. It's a teamwork. It's really a huge and ongoing efforts from everybody. The main corner of this effort starts from the hospital director and medical administration effort. They supervise all these efforts. Medicine department, including infectious disease, infection control department, preventive medicine, and public health department. We are all working in a team. So, for example, medicine department, they are the one who are responsible for the patient's care, especially in the first 3 months before we built the COVID unit. We established therapeutic protocol, which is updated regularly. Then after or in June, we started to establish also the COVID units that everybody from other medical subspecialties, they shared in it. And thank you for everybody who shared us in taking care of patients with COVID. We opened virtual clinic, establishing, some policies and procedure. Infection control, they are responsible, of course, for monitoring putting a policy and procedure in regard to infection control measures. They were monitoring the adherence of healthcare workers to this practice. They have a link or a communication between with MOH and Saudi CDC. Preventive medicine, they were screening suspected COVID healthcare workers and others. Public health, they were responsible for educating, preparing educational material, and so on and so forth. At the time will really not be enough to show you all the efforts and done and still are continuing. So these are different teams: CQI, emergency department, hospital engineering, ICU, patients affairs, supply, purchasing, microbiology and central lab, pharmacy, nursing department. And it's worth mentioning that over the last initial 5 months, we were meeting on daily basis almost. And then with the stabilizing, with the decline of the cases, this meeting is becoming less frequent. So the message that when we work together, we can make a difference. So sorry for taking a long time, but the take-home points, coronaviruses is the most prominent example of viruses that has crossed the species barrier from wild animals to humans, like SARS, MERS-CoV, and recently COVID-19. SARS-CoV-2 is primarily spread from person to person through respiratory particles or droplet infection, and through also contaminated surface. Populations at risk of severe infection are those with underlying comorbidities and elderly people, immune compromised patients as well. Despite a flood of SARS-CoV-2 research is published every week, the current knowledge of this novel coronavirus is just a tip of the iceberg. Due to lack of effective antiviral therapy and vaccines at the present time, although as you heard from the social media that there are 4 vaccines now that showed efficacy in preventing the COVID. But we still need to depend solely on the implementing effective infection control measures in community and in healthcare setting. And lastly, again, I will say that we all do better when we work together. Thank you very much for listening. Hello? Can you hear me?
Yes, Doctor. There's a few questions in the question and answer. If we can answer it quickly before closing.
Yeah, okay. Go ahead.
There's one question is about asymptomatic COVID cases. How many days should be in isolation at home? And he make other question, does it different in healthcare worker or not? And after isolation, will he be infectious to other? Should he repeat the PCR after isolation? So the first few questions is about the days of the isolation, and is it different from the healthcare worker or not? And does he need to repeat the PCR?
Okay.
If you can, if you want to answer, Dr. Ansween.
Hear me?
Yes, yes, clear.
Yeah, please let me know if I really hate this virtual sort of meeting because I don't know the interaction and I cannot appreciate if people can hear me. For the question in regard to asymptomatic cases and isolation, of course, as asymptomatic COVID cases, they are diagnosed when they have exposure to confirmed COVID cases. So the isolation will start from day 1 of the positive test up to 10 days. By 10 days, after 10 days, I mean, they are usually non-infectious. And this is confirmed from studies. It's not just a arbitrary, decision. So after day 10 for asymptomatic patients, they are not anymore infectious. That's why the last recommendation is to go by symptoms-based strategy. And it is applied for both healthcare workers and non-healthcare workers. Okay. What is
Okay,
the
the
other
last,
part?
the last one is did he need to repeat the PCR after isolation?
No, Asymptomatic? No, they don't need to repeat PCR, and even for mild to moderate cases. If for talking about symptomatic cases, in addition to the duration of 10 days from the onset of symptoms, we have to make sure that the fever disappeared for at least 24 hours and the other symptoms improved as well.
Okay. There's other question is about what is the update regarding the vaccine?
Okay, regarding the vaccine, there are 4 companies that announced that they manufactured vaccines, Oxford, Pfizer, and they said it has an efficacy of around 95%. But the problem of this type of vaccine that it needs a really very low temperature, minus 70 degree Celsius. So it's probably difficult sometimes to provide such a temperature. Other companies, Moderna and also AstraZeneca, and the 4th company, I forget the name, also they produced vaccine with different efficacy. Moderna and the other company, it has an efficacy of 92%. The one from AstraZeneca, it's below 90, 70 to below 90%. So we will see what is the latest update in this regard. For us in the kingdom, I think it is expected as per MOH that this vaccine will be available in the first quarter of 2021. One of these vaccines, probably the Pfizer one.
Okay, the last question. Can the winter season precipitate second wave?
We cannot predict anything about this new novel virus. So, but theoretically or hypothetically, we said that the virus is usually killed by the high temperature. So hopefully we will not have second wave, especially if we adhere to the infection control prevention measures in the community and in the hospitals. So let's hope for the best and pray.
Okay, I think this is the last question. If you want to conclude, Dr. Answin, to close the meeting.
Nothing. I just would like to emphasize on the same points that we mentioned. We need really to work hard and to work in one team and to stick to the infection control prevention measures. And thank you all for listening and attending. Thank you, Dr. Eid, as well.
Okay, thank you all for attending this command round, and see you in the next time, inshallah.
Thank you.